go over a few topics about the mechanism associated with lipoprotein A, such as introduction, methods, results, discussion, and conclusions. Coronary spasm is common, contrary to the previous concept that actually this disease is very common and deserves the same fast action as atherosclerotic obstructive coronary artery disease, CAD. There's a wrong typing, CAD. Because CAS can cause rapid plaque progression of CAD and the development of acute coronary syndrome. So it's becoming more and more important, and we physicians, cardiologists are recognizing that. It's important to identify CAS before the potential subsequent development of CAD and heart failure. ApoA, LPA, which is a major carrier of oxidized phospholipid, and alpha-7 nicotinic acetylcholine receptor may play an important role in the development of coronary artery spasm. In coronary artery spasm, the association between lipoprotein A and alpha-7 nicotinic receptor, modulated inflammatory macrophage polarization, and activation and smooth muscle cell dysfunction remains unknown. Various arrhythmias, especially ventricular premature complex, more often appear in 50% of coronary artery spasm angina than in classic Hippolytus angina, which is exercise angina, through unknown mechanism, but possibly involve QT dispersion. For example, in this case, VPC couplet could be reproduced by SAM provocation test, which we demonstrate in a 50-year-old female. While potentially life-threatening, ventricular fibrillation can be spontaneous recovers in 10 seconds without interventions, as shown here. In addition, coronary spasm could lead to syncope, heart failure, other arrhythmias, and myocardial ischemic syndromes, such as asymptomatic ischemia, rest or effort angina, myocardial infarction, and sudden death. Here's another case of spontaneous recovery of VF, and this case lasts for longer than the previous one, 17 seconds, almost 20 seconds. The heart does not pump any blood throughout the heart. However, both of their consciousness remain clear. According to the medical literature, if this kind of ventricular fibrillation lasts for more than 30 seconds, then the patient will faint, will become syncope. So for the diagnosis, the current guidelines recommend class 2A indication in American ACC/AHA guidelines and European ESC guidelines, while the international study group COVADIS recommends class 1 indication. The mechanisms underlying coronary spasm are still poorly defined and are likely multifactorial, as shown here in table 1. In the 1980s, the autonomic nervous system was found to play an important role in the pathophysiology of spasm. In the 1990s, inflammation, endothelial dysfunction, oxidative stress, respiratory alkalosis, and magnesium deficiency were identified as predisposing factors. In the late 1990s and early 2000s, genetic mutations were found to be associated with coronary artery spasm. Nonetheless, vascular smooth muscle cell hyperactivity seems to constitute the final substrate for coronary artery spasm. While risk factors in an individual usually exist together and have a cumulative and interactive effect to increase a person's chance of getting spasm, precipitating factors refers to a specific event, which may act in the same patient to cause the onset of coronary artery spasm in various circumstances. Notably, while older rather than younger people are more likely to develop spasm, smoking in the younger compared with their older analogs has a more powerful effect on coronary artery spasm occurrence. In addition, as smoking and age appear to have a more important role in men, coronary artery spasm risk factors may be gender specific. So for studying lipoprotein A associated inflammation in spasm, these are our methods. We conducted a prospective cohort study with the approval of Taipei Medical University. We performed spasm provocation test. We use ergonomic administration and define coronary spasm as more than 70% reduction in luminal diameter compared with post-intracoronary nitroglycerin. We isolate patients' monocytes from the peripheral blood mononuclear cells, and then we call these cells as PMDM, patient monocyte-derived macrophages. And we differentiate these monocytes to macrophage. And we also perform analysis on lipoprotein A isolation, detection, and information analysis according to protocol. Since the late 1980s, the inflammatory and immunological nature of atherosclerosis has been reviewed by several studies in patients and experimental models, underscoring the importance of inflammation in CAD, coronary disease, as well as in coronary spasm. Investigation of disease-modifying mechanisms in these models will be crucial for developing future diagnostic and therapeutic strategies against coronary spasm, as well as coronary artery spasm-related heart failure. So here we provide an introduction to experimental models that are used for coronary spasm studies and the research techniques that can be utilized as in table 2. So in this table, our model is PMDM, patient monocyte-derived macrophage. It's a cell model. For the result, there are a total of 64 patients enrolled in this study. The median age is 58 years old, and 58 years old. And most of the coronary spasm patients, their age are between, most of them are between 40 to 70 years old. And patients in the coronary spasm group compared with patients in the control group has significantly higher lipoprotein A levels. The leukocyte monocyte macrophage and high-sensitivity values were also significantly higher in the CS group than in the control group. Single vessel spasm was the most common finding in spasm patients, and spasm was provoked mostly in right coronary artery. Lipoprotein A levels positively correlate with serum CRP, IL-6, monocytic alpha-7 nicotinic receptor levels. The LPA levels were also significantly higher in patients in CS than in the control group. Compared with the untreated group or the treatment of LDL, exposure to LPA induced more than around 10-fold increase of alpha-7 nicotinic receptor mRNA in CS PMDM. The exposure to LPA increased dose-dependently alpha-7 nicotinic receptor mRNA expression level and luciferase activity dose-dependently in CS PMDM. Methylcaconitin, which is MLA, dose-dependently inhibited the LPA-induced activation of alpha-7 nicotinic receptor. And in the bottom picture, we use molecular docking to demonstrate that the ligand binding domain of pentameric alpha-7 nicotinic receptor directly interacts with the Kringle K47, K410, and K5 domains of ApoA components of LPA, suggesting that ApoA is the active component of LPA. Okay. To evaluate if and how Okay. To evaluate if and how LPA modulates macrophage activities in CAS, which has not been studied before, we use CAD-specific functional genomics data from the National Center for Biotechnology Information Gene Expression Omnibus website to perform comparison of knowledge between CAD and CAS. Our analysis of the GSE 9820 GPL 6255 GTS 3690 dataset, which originally analyzed various circulating mononuclear cells from patients with severe CAD, revealed that the expression of alpha-7 nicotinic receptor CD206, CD163, and CD20 and CD80 was the highest in macrophage compared to the CD14 resting monocytes, CD34 stem cells, LPS stimulated monocytes or CD4 T helper cells. In addition, the median CD80 macrophage population was 1.5-fold more than the CD206 macrophage. In our CAS monocyte-derived macrophages, LPA compared with the LDL elicited 3.0-fold stronger shift in fluorescent intensity of the CD80 macrophage population. However, exposure to neither LDL nor LPA had any apparent effect on the median fluorescent intensity of the CD206 macrophage, suggesting that LPA preferentially induced M1 macrophage polarization in patients with CAS. Exposure to LPA significantly increased the macrophage expression of alpha-7 receptor, phosphorylated P38 MAPK, and IL-6 proteins in a dose-dependent and time-dependent manner. A similar dose and time-dependent induction of the expression of alpha-7 receptor, P38 MAPK, IL-6, RhoA-GTP was observed in human coronary artery smooth muscle cells. To further understand the influence of LPA on the RhoA-GTPase, we examined the activation of an important RhoA-GTPase, RhoA-GTP, and its downstream effector, ROCK activity. We found that LPA dose-dependently activate ROCK, while treatment with LPA enhanced the expression of alpha-7 receptor, P38 MAPK, and RhoA-GTP protein in unsilenced negative control human coronary smooth muscle cells.
Excuse me, one question. What kind of cells are they?
Human coronary artery smooth muscle cell from cell line. Smooth muscle cell. Yeah. No. No. The smooth muscle is a muscle cell. Yeah.
So this sample you took out and after patient got some exercise.
No, we bought it from. It's commercially available.
Oh, you bought this from company which have two populations, normal and with this problem, or what these problems?
No. These are primary cells. Primary human coronary smooth muscle cells.
That's very interesting. I still want to follow up at this because
we try to isolate human coronary smooth muscle cell from patient-derived, but it's easily failed because they cannot survive long.
But when you do this analysis, how do you connect it to cardiovascular problem? Study test. So this sample is, it means the patient is already sick, right?
Yeah.
And you have to buy normal material from them for comparison. Is that right?
Yes. Actually, this coronary artery spasm is patients. They are not as weak as CAD patients in terms of physical. and psychological. Yeah. Did you?
Is there any surgical intervention at the spasm, or is it just based on like medications or medications for the patient?
Medication is the cornerstone of therapy, but
like statin, like channel blockers, like
calcium channel blockers.
Oh yeah, what
is the mainstay.
No surgical, no evidence based that you have any surgical intervention on it.
Stenting or surgical is okay, but only when the patient is not responsive to medication.
Oh, okay.
Yeah.
Most of these patients, the coronary is open.
Yeah, yeah.
Yeah, but he's discussing whether the patient is sick, so you know.
The coronary spastic are spastic sometimes, not all the time. Yeah. So sometimes they will develop into myocardial infarction or sudden death without any warning sign.
One question again. How did you treat cells with
These patients?
You have a Western blot over there. Yeah. So different. It is different. My eyes, I cannot see that. Is it different compounds of what treatments you run Western blot or different sample numbers?
No, they are the same.
How come you do that?
Yeah.
What is on top of this? Different concentration, okay. Different concentration. Okay. Beautiful question. Thank you.
Okay, I will continue. To further understand the influence of LPA on the RhoA-GTP, we examine the activation of important RhoA-GTP, RhoA-GTP, and the downstream ROCK. While treatment with LPA enhances the expression of alpha-7 receptor, P38 MAPK, and RhoA-GTP protein in unsilenced native control human coronary muscle cells, compared to untreated cells, its enhancing effect on alpha-7 receptor, P38 MAPK, and RhoA-GTP protein levels were significantly reduced by short hairpin RNA of chRNA7 function. The chRNA7 is the gene component of alpha-7 receptor. Okay. Suggesting that the activation of P38 MAPK signaling in macrophage and human coronary muscle cells by LPA is alpha-7 receptor dependent. On the other hand, while short hairpin chRNA7 exhibited no suppressive effect on the CD80 M1 macrophages in the absence of LPA, exposure to LPA significantly enhanced the ability of short hairpin chRNA7 to suppress the fluorescent intensity of CD80 M1 cells. When patient monocyte-derived macrophages were treated with increasing concentrations of LPA, the nitric oxide production and the expression of inducible nitric oxide synthase were dose-dependently inhibited. So in summary, from these figures, we demonstrate that promoting inflammation in patient monocyte-derived macrophage and human coronary muscle cells by inducing alpha-7 receptor dependent activation of P38 MAPK signaling. That's the main message. Okay. Here we use a drug tocilizumab. You can see that the last 3 words is MAP. That means monoclonal antibody. So this is the monoclonal antibody against IL-6, tocilizumab. So we use this product to do the next experiment. For the rational selection of therapeutic monoclonal antibody to examine whether LPA could be a potential target, tocilizumab an anti-IL-6 receptor monoclonal antibody with the chemical structure was used. Treatment with tocilizumab exhibited no obvious toxic effect to the patient monocyte-derived macrophage and human coronary muscle cells. Furthermore, exposure to tocilizumab dose-dependently and significantly reversed the LPA-induced upregulation of alpha-7 nicotine receptor P38 MAPK protein expression levels in both patient monocyte-derived macrophage and primary human coronary artery smooth muscle cells, and additionally, RhoA-GTP in human coronary muscle cells. The RhoA-GTP is the constricted component of smooth muscle cells. If RhoA-GTP is activated, the smooth muscle cell will be constricted. Okay. So this is the graphical abstract. Serum lipoprotein A levels are positively correlated with the levels of CRP, IL-6, and monocytic alpha-7 receptor in coronary artery spasm. LPA induces macrophage M1 polarization, and through its ApoA chain, the expression of alpha-7 receptor, P38 MAPK, and IL-6, and those dependently inhibited the nitric oxide production and the expression of inducible nitric oxide synthase in the patient monocyte-derived macrophage with CAS. Lipoprotein A activate human coronary muscle cells via alpha-7 receptor, P38 MAPK, IL-6, RhoA-GTP signaling axis induction. Tocilizumab anti-IL-6 antibody reduces the interaction of LPA monocyte, human coronary muscle cells, and the subsequent expression of alpha-7 receptor, P38 MAPK, IL-6, RhoA-GTP, suggesting that alpha-7 receptor partly under the influence of IL-6 and anti-cytokine IL-6 as a promising treatment of coronary spasm. So this study provides a new avenue in understanding the process of alpha-7 receptor-induced vascular smooth muscle cell dysfunction and shows promise in the development of potential therapeutic agents for coronary spasm. However, not just the coronary spasm not just cause angina or myocardial ischemic syndrome. They also cause heart failure. And this is a summary of the current medical literature and just published in this January in International Journal of Molecular Sciences, from basic to clinical. Traditionally, unless contraindicated, heart failure reduced ejection fraction should be treated with beta blocker, angiotensin receptor nebulizing inhibitor, ARNI inhibitor, angiotensin converting enzyme inhibitor, that is ACEI, or angiotensin receptor blocker, that is ARB, with the addition of a mineralocorticoid receptor and agonist in patients with prominent symptoms, while evabradi and hydrolysine isosulfide dinitrate may also be considered in the management of heart failure reduced ejection fraction. More recently, sodium glucose cotransporter 2 inhibitor, SGLT2 inhibitors, have much improved disease outcomes, reducing cardiovascular and all-cause mortality regardless of diabetes status. So even you have no diabetes, if patients have heart failure, SGLT2 anti-diabetic drugs is good for the heart failure treatment and the related outcome. And also another drug, vericiguat, which is a stimulator of soluble guanylate cyclase, reduces inpatient admissions for high-risk heart failure reduced ejection fraction. Additionally, patients with CAS-related dilated cardiomyopathy have a higher prevalence of atrial fibrillation than those without. Therefore, dilated cardiomyopathy with AF is probably an indication to identify coronary spasm. So taken together, although no guideline addresses the therapeutic significance of calcium channel blockers in coronary spasm-related heart failure, the differential diagnosis of dilated cardiomyopathy or heart failure reduced ejection fraction should include coronary spasm, since calcium channel blockers are potentially promising medical options. On the contrary, medication classes that are efficacious in heart failure reduced ejection fraction have been less so in heart failure preserved ejection fraction. The heart failure preserved these medications decrease the risk of inpatient admissions, but not cardiovascular or all-cause mortality in heart failure preserved ejection fraction. So these observations underline the significance of non-cardiac comorbidities and underscore the complexity of pathophysiological mechanisms, both cardiac and non-cardiac, underpinning heart failure preserved ejection fraction. So in this figure, figure 6, is a graphical abstract depicting the multifactorial molecular and cellular mechanism involved in the initiation and progression of CAS here, and CS-related preclinical heart failure to clinical overt heart failure. Coronary spasm-related heart failure cannot be improved by interventional revascularization, and medications are the cornerstones of treatment. The coronary spasm induce abnormal regional wall motion abnormality, dilated left ventricular, and reduced systolic function improve 6 months to 1 year by medications, including calcium channel blockers and nitrate nicorandiol, which is contrary to many cardiologists so far, many cardiologists' concept that calcium channel blocker is contraindicated in heart failure. Actually, this is not a contraindication. This is relative contraindication. In coronary spasm, calcium channel blockers, even the patient has heart failure, the calcium channel blocks can reverse the heart failure, and the patient's heart will become normal. I have seen this case over and over again, many times. And heart failure reduced ejection fraction in Syrian hamsters, experimental animal models, and in German patients with microvascular disease possibly caused by coronary spasm can be improved through vasodilator effect by the medical treatment with verapamil and diltiazem, respectively, due to improved ischemia. The development of CAS can be contributed by smoking, CRP, and LPA. Mediated through alpha-7 nicotinic receptor, the reversible nature of CAS heart failure is suggested and represented by a reciprocal relationship and a positive feedback loop between epicardial and microvascular CAS. Most oftentimes we only see epicardial spasm. Microvascular, because they are too small, it's not visionable. But actually, these two entities are affecting each other. Fasudil here, tocilizumab, carcinol, and RhoA-GTP are potential disease-modifying therapies of coronary spasm. Although Fasudil, which is a RhoA kinase inhibitor, prevents acetylcholine-induced coronary spasm and associated myocardial ischemia, its role in spasm heart failure remains unknown. In some patients with refractory symptoms, the soluble guanylate cyclase stimulator RhoA-GTP, which is licensed for pulmonary hypertension, has been reported to resolve recurrent and refractory CAS-induced angina. So in conclusion, serum lipoprotein A levels are positively correlated with the levels of CRP, IL-6, and monocytic alpha-7 receptor in spasm. LPA induces macrophage M1 polarization, and through its ApoA chain, the expression of alpha-7, P38 MAPK, IL-6, and dose-dependently inhibited the nitric oxide production and the expression of inducible nitric oxide synthase in the monocyte-derived macrophages with CAS. Lipoprotein A activates human coronary small muscle cells via alpha-7 nicotinic receptor P38 MAPK IL-6 RhoA-GTP signal induction. Tocilizumab reduces the interaction of LPA monocyte human coronary muscle cell and the subsequent expression of this inflammatory signal transduction, suggesting that alpha-7 nicotinic receptor is partly under the influence of IL-6 and anti-cytokine IL-6 is a promising treatment of CAS. Our study provides a new avenue of understanding CAS.
Go back one question.
Sure.
Go back to the same slide. No, this yellow card, yeah. For number 2, number 3, I'm asking the signaling pathway. You have P38 over there. We have interleukin 6 there. Who activates whom? Those P38 activate interleukin 6, or interleukin 6 activate P38 is my question. What comes first?
In our study, the analysis of the order of the analysis in our experiment is P38 MAPK, then IL-6.
Okay.
But according to literature, these are affecting each other. Yeah.
So if you have IL-6 and protein, RNA, all go up, activated by P38?
I think so, but we did not demonstrate the data.
Have you ever used P38 inhibitor SP compound? Look at your parameters. See something you treat with SP, IL-6 will go down.
Yeah, that's a good idea. Maybe we will try next time. Yeah. This is a very big topic. It's becoming big and big. Even Mayo Clinic, even Stanford University, they understand that. This is very important, but to my surprise and to my disappointment, many cardiologists, they don't recognize the importance of this. They even tell the students when my patients they go from Taiwan to Canada to the United States, their cardiologists told them spasm is nothing. You don't need to take medications. This is wrong. Well, I don't think I need it, but you need one? Okay. I will give you later. So these are, I just like in the beginning, I said I've been doing this for 20 years, and along the way, this is a lonely way because not so many patients, not so many physicians can see the vision. So these are very important people. They are helping me walk through the difficulties, such as Dr. Smikas, which is and Joe Wisdom. They are very famous. They are well known for lipoprotein A. And Professor Kunis, who is now living in Greece, he was the first to describe Kunis syndrome. Kunis syndrome is an allergic angina, which is caused by coronary spasm. And now we have a few collaborations and some manuscript productions. Okay, so if you have any questions, I know many of you are not cardiologists, but you go back to your place, you are more than welcome, and I'm pleased to tell you that you can tell your friends to a cardiologist to, if they are interested, they can connect with me with email. Yes, we are designing a mouse model. I think it will come out not very quick, but maybe next year or next 2 years. So far in the world, there are no mouse models for coronary spasm. The most successful model of coronary spasm is pig, which is from Japan.
Mechanism that you've been describing as an inflammatory response type process, is that a complete different mechanism than cocaine-induced coronary artery spasm that we also see from time to time in the hospital?
I think they are not different, but yeah, you mentioned the important thing that cocaine, amphetamine, yeah, they can cause coronary spasm, but the mechanism, to the best of my knowledge, very few papers discuss the mechanism, because these kind of patients are not many. The population is not big, so it needs some collaboration to collect the data and collect their blood to see what happened inside.
Yeah. Last question for you. You generally go with diltiazem versus verapamil initially when you're trying to treat patients for this syndrome. If you're not using, tocilizumab or one of these other agents that you're describing right now, what's your first line treatment?
Okay. All these 4 drugs in purple line, in purple circle, all these 4 drugs except fasodiol are under investigation for spasm use. So the first line treatment, according to the guideline, is still calcium channel blocks, usually long acting, diltiazem, verapamil, and yeah. Because long acting calcium channel blocks, not short acting, and some doctors would say that don't use non-hydrotherapeutic CCB, but in my opinion, any CCB is fine. Some would say don't use verapamil or diltiazem. I don't know why, because I use this medication very well, and patients' response are good. So any long-acting CCB is good. Just don't use short-acting, such as nifedipine. But you can use long-acting nifedipine, ORS, diet ORS. That's okay. But some medications for hypertension, such as Novosk, amlodipine, the effect of anti-spastic effect is not very strong. So in my experience, they don't affect the spasm in terms of symptoms or EKG. You have to use diltiazem or verapamil, that kind of thing. Thank you.
Question for you. Have you ever treated a patient whose heart and lung are fused together? Heart and lung are fused together and then spasm in the heart. Racing.
You mean puff? Like nebulizer?
A nebulizer?
To treat heart and lung together?
Yeah.
You mean use this medication?
My mother was born with a rare St. James Forest syndrome, which means she had a deformed lung. So one lung was removed. During surgery, the surgeon left a hole in the chest cavity, and the other lung herniated through that hole. And the heart and lung have fused together. So it's quite a challenge. Like I said, cardiologists don't know so much around it, you know, so it's a real rare case.
So is she restricted on exercise?
Yes.
Okay.
Very much.
If I were her doctor, I will prescribe this medication, RhoA-GTP, because it's initially RhoA-GTP is initially licensed for pulmonary hypertension, for pulmonary treatment.
Okay.
But later it was found to increase nitric oxide
Mhm.
production in both lung and heart.